Hello, I am Dr. Soumik Goswami, an assistant professor of endocrinology at NRSMCH Kolkata. Today I'll be discussing an approach to hypercalcemia in terms of the principles of its evaluation and management. Now, hypercalcemia is something which is pretty common, especially in an inpatient setting where about 1 out of every 100 to 150 patients might report hypercalcemia. In the outpatient setting, the incidence of hypercalcemia varies from about 1 in 500 to 1 in 1000 patients depending on the age group that you are dealing with. And this evaluation and management of hypercalcemia is important not only for internists but other specialties as well, including oncologists and surgeons. Today we'll be looking at the basics of calcium metabolism. We'll be looking at how to identify true hypercalcemia, history, clinical presentation, basics of diagnostic approach to hypercalcemia, and we'll be dealing with the principles of management of hypercalcemia. If we look at the basic physiology of calcium metabolism, calcium in the body is tightly regulated because the intracellular calcium concentration is several orders lower compared to the extracellular calcium concentration, and the extracellular calcium concentration is maintained tightly by a number of mechanisms. The primary source of calcium for humans is diet, and in case your calcium level falls in the body, the primary mover, the primary hormone which starts going up is the parathormone or the parathyroid hormone secreted by the parathyroid glands. Increase in parathyroid hormone stimulates the release of calcium from the bone, increases calcium reabsorption in the kidneys, generates more of active vitamin D in the kidneys, generates more of calcitriol in the kidneys, which in turn increases the absorption of calcium from the intestine. So a decrease in calcium triggers a number of pathways which helps restore calcium levels to normal. On the other hand, if there's an increase in calcium levels above normal, it acts on the thyroid gland to release calcitonin, which in turn causes calcium deposition in the bone and increases calcium excretion through the kidneys, again to restore calcium levels to normal. So if you look at the three prime movers of calcium homeostasis within the human system, parathyroid hormone increases the level of calcium, but at the same time it decreases the level of phosphate. It increases phosphate excretion through the kidneys. Vitamin D3, the active form of vitamin D3, increases the level of both calcium and phosphate, acting primarily at the level of the intestine and to some extent also at the level of the kidneys. Calcitonin reduces the level of both calcium and phosphate, and these are the three main hormones which play a role in calcium and phosphate metabolism. Now, most of the calcium that is there in the human body resides in the skeleton. Only about 2% is found in the plasma, and a very small amount is found within the cells. The free calcium that is there, which we can measure, is actually consisting of two parts. A part of it is ionized calcium, which is the actual free calcium responsible for a number of metabolic processes, and the rest of it is calcium which is bound to proteins, predominantly albumin. So the calcium that you measure when you measure the total serum calcium consists of roughly 50% of ionized calcium or free calcium, which is the active calcium responsible for metabolism, and 50% of bound calcium, which is predominantly calcium bound to albumin. So for if some reason there is a increase in albumin levels, for example due to dehydration, there could be pseudo hypercalcemia if you measure the total serum calcium. In multiple myeloma, certain paraproteins may lead to an increase in total serum calcium because of increase in the bound form of calcium. On the other hand, if due to malnutrition or if due to illness, the albumin levels come below normal, you can have a false normal total calcium in the face of increased ionized calcium. So the gold standard to say that a person has hypercalcemia is actually measurement of free calcium or ionized calcium, which should be done in a state of fasting and which should be done without venous occlusion, because venous occlusion has been reported to falsely elevated the measured calcium value. If you do not have access to measurement of free calcium or ionized calcium, you can use a derived uh, formula for correcting the total calcium, where depending on the albumin level, you can increase or decrease the level of the total calcium to get corrected total calcium. The basic premise here being the fact that for every 1 gram per deciliter increased in the measured albumin, the increase in total calcium is about 0.8 milligrams per deciliter. If we take an example here, for example, if you measure the total serum calcium to be 12 and the corresponding albumin level to be 2, it means that if you consider the ideal albumin level to be 4, there's a decrease in the measured albumin by 2. So for every 1 gram of deciliter increase in albumin, as we discussed earlier, the calcium increases by 0.8 milligrams per deciliter. So here it is 4 minus 2, which gives us 2, multiplied by 0.8, which gives us 1.6. You add 1.6 to 12 and you get the value of corrected total calcium as 13.6. However, this formula has certain fallacies. It can at times lead to falsely high or falsely low results. So the gold standard to say that a person has hypercalcemia remains measurement of free calcium or ionic calcium. Now, after you have stamped that yes, this person has hypercalcemia, you need to classify hypercalcemia into mild, moderate, and severe hypercalcemia. And this is important from a management point of view. So someone with a total calcium of say between 10 to 12 milligrams per deciliter, the ionic calcium of about 5.6 to 8 milligrams per deciliter is said to have mild hypercalcemia. The next level of moderate hypercalcemia denotes a ionized serum calcium of between 8 to 10 millimoles per liter. And if you have higher levels than moderate hypercalcemia, you are said to have a hypercalcemic crisis. And this classification is important from a management point of view, as we shall soon see. Now, what are the causes of hypercalcemia? Causes of hypercalcemia can be broadly divided into PTH dependent causes and PTH independent causes. Amongst the PTH dependent causes, of course, the most important cause is primary hyperparathyroidism, which could again be due to either parathyroid adenoma, single or multiple, or could be due to parathyroid hyperplasia. Vitamin D can increase the levels of calcium independent of PTH levels, either the use of vitamin D as cholecalciferol in excess, or in certain diseases there is increased endogenous production of 1,25-dihydroxyvitamin D or the active form calcitriol, which leads to increase in calcium. Certain malignancies, particularly lung cancer, renal cell cancer, multiple myeloma, by a variety of mechanisms can increase serum calcium, most important of which is through the generation of PTHRP or parathormone related peptide, which acts like parathormone to increase serum calcium but is not exactly similar to parathormone. Certain medications, particularly thiazide diuretics, theophylline, are known to cause hypercalcemia. Certain endocrine diseases by a variety of mechanisms, including acromegaly, hyperthyroidism, pheochromocytoma, and adrenal insufficiency, are known to cause hypercalcemia. Genetic cause, the most important genetic cause is familial hypocalciuric hypercalcemia, where due to a defect in the receptor, you get decreased calcium excretion through the kidneys with the resultant increase in serum calcium levels. Now, the symptoms or the presenting features of patients with hypercalcemia varies. A good proportion of hypercalcemia, which is picked up nowadays, is actually asymptomatic hypercalcemia, where because of the routine chemistry panel, the biochemistry panel which is done, you often pick up mild forms of asymptomatic hypercalcemia. However, there may be patients who could be symptomatic, and the symptoms could vary from a permutation and combination of different systems across the body. Hypercalcemia is known to affect the kidneys, forming stones which could lead to renal colic in severe cases, and is also known to cause polyuria, polydipsia, nephrocalcinosis, and diabetes insipidus, and even renal tubular acidosis. Affection of the bones might lead to pain in the bones, might lead to fracture in the bones. Pain might be a result of pancreatitis. Other gastrointestinal features include nausea, anorexia, vomiting, constipation. The central nervous system might be affected so that the patient might be lethargic, the patient might be confused, and they emit groans, the so-called classic groans of hypercalcemia. The cardiovascular system might be affected in the form of a shortening of the QT interval, in the form of bradycardia and hypertension. So multiple systems might be affected in different permutation and combination, but a big number of patients with hypercalcemia might actually be totally asymptomatic. Now, if you look at the clinical clues as to the etiology of hypercalcemia, in primary hyperparathyroidism, most of these individuals present with milder forms of hypercalcemia, and they are usually asymptomatic. However, being asymptomatic is always not a rule. There could be some patients who present with the symptoms and signs that I was talking of in the earlier slide. It is usually a decade of the rather a disease of the 6th decade of life. So it is seen in middle-aged to elderly women particularly, rarely seen below the age of 15 years. The patients usually come with a normal physical examination. And in certain instances, there could be a family history of hyperparathyroidism, particularly if the patient is suffering from the so-called multiple endocrine neoplasia syndrome 1 or 2A. The malignancies which lead to hypercalcemia are usually severe enough to be manifest much earlier than the detection of hypercalcemia. They are usually advanced malignancies with metastasis, and these patients are grossly symptomatic because the hypercalcemia is more severe and the malignancy per se is in an advanced stage which causes hypercalcemia. Diet per se rarely causes hypercalcemia, but as we discussed earlier, there are certain medications which could cause hypercalcemia, like thiazide diuretics, like lithium, like theophylline. In terms of diet causing hypercalcemia, milk alkali syndrome due to a consumption of excess milk along with alkalis was earlier the norm in the treatment of peptic ulcer disease, which nowadays has gone out of fashion. So that dietary part of milk, excess milk leading to hypercalcemia, is not commonly seen nowadays. In patients who are otherwise asymptomatic with milder forms of hypercalcemia, and if you have a number of past records showing hypercalcemia, particularly from early childhood or childhood, it often denotes the presence of familial hypocalciuric hypercalcemia, which is a genetic defect present right after birth. The first step in the laboratory evaluation of a patient of hypercalcemia, after you have diagnosed hypercalcemia with certainty and looked for clinical clues as to what could have caused hypercalcemia, the first step in the laboratory evaluation of hypercalcemia is the performance of a serum parathormone assay. Now when we measure the serum iPTH or intact parathyroid hormone, it is important to keep in mind that parathormone is a thermolabile hormone. It's a peptide. So you need to uh, get the sample assayed as quickly as possible, preferably using a cold centrifuge. So if you draw the sample, keep it at room temperature for a prolonged period and delay the assay, you could get a falsely low level of parathyroid hormone. If the parathyroid hormone is above the upper limit of normal, you usually suspect primary hyperparathyroidism or hyperparathyroidism. It could even be tertiary hyperparathyroidism with hypercalcemia, of course. The other conditions where parathyroid hormone could be somewhat elevated are the intake of lithium with hypercalcemia or familial hypocalciuric hypercalcemia, which is also associated with a slight elevation of PTH level. So if you have an elevation of PTH level, these are the three conditions that you need to keep in mind. Now, what if the PTH that you measured is just above normal or high normal? For example, if you take the upper value of normal of PTH to be 65 picograms per ml or 70 picograms per ml, you could get patients who come to you with a PTH of say 75 picogram per ml or just 65 picogram per ml. Now, what to do with these patients? Do they have primary hyperparathyroidism or do they have something else? The next step would be the measurement of 24-hour urine calcium excretion. The 24-hour urine calcium excretion is considered to be elevated if the total urine calcium excretion is more than 200 to 300 milligrams per day or the calcium creatinine ratio is more than 0.02. It is considered to be low if the calcium creatinine ratio is less than 0.01, and anything in between is considered to be normal calcium excretion. Now, if you get a high normal or slightly above normal iPTH and your 24-hour urine calcium excretion is high, you are dealing with primary hyperparathyroidism. If your 24-hour urine calcium excretion is low, you are likely dealing with familial hypocalciuric hypercalcemia, but there is a small possibility that it would also be primary hyperparathyroidism with vitamin D deficiency, in which case you assay serum vitamin D levels. If it is normal, you can say this is familial hypocalciuric hypercalcemia. If it is low, you replace vitamin D in that patient, reassess urinary calcium excretion, and then decide whether it was familial hypocalciuric hypercalcemia or PTH with vitamin D deficiency. If your 24-hour urine calcium excretion is normal, it is likely to be primary hyperparathyroidism with vitamin D deficiency, but there's a small possibility of it being familial hypocalciuric hypercalcemia as well. Again, you measure the serum vitamin D levels. If it is normal, in that case, it is likely to be primary hyperparathyroidism. If it is low, it is likely to be if it is low rather, you replace vitamin D, you reassess the urine calcium excretion. If the urine calcium excretion is still low, you can then stamp that this patient has familial hypocalciuric hypercalcemia, and if after vitamin D repletion the urine calcium goes up, in that case the patient was having primary hyperparathyroidism with vitamin D deficiency. Now what if the PTH is low? We were talking of in the earlier two slides about PTH dependent hypercalcemia. It could be outright elevation of PTH, a mild elevation of PTH or high normal PTH. Now what if the PTH was on the lower side, less than 20 picograms per ml? The causes that are now considered are: one, as we discussed earlier, PTH RP excess, parathormone related peptide excess, which acts like parathyroid hormone but since it itself acts like parathyroid hormone to increase calcium levels, the increased calcium suppresses the endogenous native parathyroid hormone. And this is obviously seen in humoral hypercalcemia of advanced malignancies. Rarely you would get a person who takes a lot of cholecalciferol leading to vitamin D intoxication. Rather, calcitriol intoxication is something which can be more commonly seen, where the doctor prescribes calcitriol in excess of the requirement, or in a situation where cholecalciferol would have been the preferable drug rather than calcitriol. Some diseases like lymphoma, sarcoidosis, lead to increased 1-alpha hydroxylase activity and subsequent generation of the active form of vitamin D in the human body. But again, these diseases are not very common, and when they lead to increased calcitriol generation, they are usually in an advanced stage and are picked up quite easily. There could be other causes of PTH independent hypercalcemia as well, including hyperthyroidism, adrenal insufficiency, immobilization, and milk alkali syndrome. Interestingly, there are certain other causes besides familial hypocalciuric hypercalcemia, where in spite of there being hypercalcemia, the urinary calcium excretion is reduced. Two such causes include the use of thiazide diuretics and milk alkali syndrome with hypercalcemia. Now, as we discussed earlier, the prime hormones and the prime chemicals which regulate calcium levels also have an effect on the serum phosphate level. So measurement of a serum phosphate level is also useful in delineating the etiology of hypercalcemia. If you have a low serum phosphate level with hypercalcemia, it usually points to either primary hyperparathyroidism or the presence of elevated parathyroid hormone related peptide. A normal or elevated phosphate level hints that you are dealing with either granulomatous diseases or vitamin D intoxication situations where there's an increase in the active form of vitamin D leading to increase in both calcium and phosphate. Other causes of both the calcium and phosphate being elevated include immobilization, thyrotoxicosis, milk alkali syndrome, and the presence of extensive skeletal metastasis. Some other tests which carry I would not say a lot of significance, but carry some significance, or they could sort of support the diagnosis that we are looking for, including assessment of serum chloride and serum bicarbonate. If your serum chloride is elevated with a slight decrease in serum bicarbonate, it points to primary hyperparathyroidism. Lowering of the serum chloride with normal or elevated serum bicarbonate points to the milk alkali syndrome. If you do an X-ray of the hands and if you get osteitis fibrosa cystica, you are almost certain that this is primary hyperparathyroidism, although per se it is not very common in primary hyperparathyroidism, seen in about 1 out of every 20 patients. Similarly, band-shaped keratopathy, which is not a very common finding, but if it is there, it suggests that the underlying cause of hypercalcemia is primary hyperparathyroidism. Just a brief glimpse of how to localize the suspected lesion in a case of primary hyperparathyroidism, since it happens to be one of the commonest causes of hypercalcemia. After you have stamped that this patient has hypercalcemia and this increased hypercalcemia is PTH dependent due to hyperparathyroidism, the next step would be localization of the incriminating lesion. The usual investigation which we do is a 99 technetium sestamibi scan of the neck and the mediastinum to look for any parathyroid adenoma, either at a eutopic or ectopic position. Ultrasonography with an experienced observer has the same sensitivity and specificity as a technetium scan, but it's not readily done by most sonologists. 4D CT scan has somewhat greater sensitivity and specificity than either of these modalities. However, it is not freely available and it's not available in the city of Kolkata at present. Now, coming to the management of hypercalcemia, the final part of this discussion, there are four basic pillars of management of primary of hypercalcemia. One is to use saline hydration and diuresis. Two would be the use of bisphosphonates. Three would be the use of glucocorticoids or denosumab. And the fourth would be the use of calcitonin. How and where to use it, we'll come to that very soon. In patients with mild hypercalcemia, you can go slow and steady. Immediately, you do not need to do anything active. Rather, if the patient is on drugs which can worsen hypercalcemia or which can per se lead to hypercalcemia, like thiazide, diuretics, and lithium, you need to take the patient of these drugs. You need to avoid inactivity because immobilization can actually worsen hypercalcemia. You need to keep the patient well hydrated, and this hydration can be done orally. You do not need intravenous hydration in mild hypercalcemia. And you should avoid the patient taking a high calcium diet. At the same time, you should try to pinpoint the etiology of hypercalcemia, and if you find it, you should go for specific treatment to avoid further worsening or prolongation of hypercalcemia. Coming to moderate hypercalcemia, you do need to treat it a bit more actively than mild hypercalcemia, but the intensity of treatment or your aggressiveness of treatment will depend on the course of hypercalcemia. If it is rapid onset hypercalcemia causing altered sensorium, you need to treat quickly. On the other hand, if it is a slowly progressive insidious hypercalcemia, even moderate hypercalcemia can be treated a bit less aggressively. Other than the precautions that we follow for mild hypercalcemia, in cases where there is rapid onset of symptoms like altered sensorium, we need to treat moderate hypercalcemia as we would do for severe hypercalcemia, where intravenous saline and bisphosphonates are administered aggressively to bring down the serum calcium level to normal within the next 48 to 72 hours. So what is done in patients with serum hypercalcemia? The cornerstone of therapy is aggressive fluid replacement, where intravenous normal saline is begun at a rate of 200 to 300 ml per hour, and the rate is gradually adjusted to maintain a urine output of about 100 to 150 ml per hour. The plan being to replace fluid and cause adequate diuresis to bring down the serum calcium levels rapidly. Salmon calcitonin has a role in severe hypercalcemia, where it is given either subcutaneously or intramuscularly at a dose of 4 to 8 international units per kg, twice to 4 times daily for the first 48 hours. At the same time, you begin a bisphosphonate, which is preferably zoledronic acid, given slowly over 15 minutes. You can give it even more slowly if your patient has underlying moderate renal disease. The concept here is that the fluid hydration begins to act immediately. Salmon calcitonin begins to act immediately, but we know that over a period of time, tachyphylaxis occurs to the action of salmon calcitonin. The bisphosphonate takes about 2 to 3 days to begin acting, and during that period, it's the fluid hydration and the salmon calcitonin which is doing the trick, after which the effect of bisphosphonate kicks in to reduce the level of calcium to normal. In individuals with severe renal impairment, where your estimated GFR is less than 15 or in some cases even less than 30, the use of zoledronic acid is contraindicated, and in these cases you can use denosumab in a dose of 120 milligrams up to 120 milligrams subcutaneously. It can also be used in patients who have been given a bisphosphonate but who are refractory to the action of bisphosphonate. Now, if you need to give zoledronic acid for a second time in a patient whom you feel who is not responding to zoledronic acid, you need to wait for at least 7 days. With denosumab, you need to wait for at least 1 month before you repeat denosumab if you feel that it needs to be given to reduce the level of calcium further. A big change which has happened in the management of hypercalcemia, particularly severe hypercalcemia, is the use of loop diuretics, because if you look at older guidelines, older textbooks, loop diuretics like furosemide was the standard of care along with fluid replacement intravenously. But it has now been seen that if you give loop diuretic routinely to all patients, there could be some detrimental effect. So it's now reserved for patients with concomitant heart failure or concomitant renal failure, where you cannot give intravenous aggressive normal saline without the adjuvant use of a loop diuretic. So a loop diuretic is used in selective patients with severe hypercalcemia nowadays. There are other therapies as well. In the most severe cases, you can consider hemodialysis, particularly if there are neurologic symptoms or if there is severe renal failure or heart failure, which precludes aggressive intravenous fluid replacement. Glucocorticoids, you can use them at doses of 20 to 40 milligrams per day of prednisolone in people who are not responding to the standard therapy of hydration, calcitonin, and bisphosphonates. Cinacalcet use can be reserved for certain settings like inoperable parathyroid cancers, in patients with secondary hyperparathyroidism and on renal replacement therapy, and in certain cases of familial hypocalciuric hypercalcemia, although most patients with familial hypocalciuric hypercalcemia are absolutely asymptomatic and do not require any treatment. Monoclonal antibodies are being developed against parathyroid hormone-related peptide, but it's still some time away before they can be available commercially for use. Gallium, mithromycin, and phosphate were used earlier, but have now been mostly abandoned because of their adverse effects. Now, after you have managed hypercalcemia, if your patient has underlying hyperparathyroidism, your work is not done yet. You need to assess the bone density. You need to look for genetic syndromes like MEN1 and MEN2A. And of course, you need to go for definitive management if you have succeeded in localizing a parathyroid adenoma, which is surgical removal of the parathyroid adenoma. Now, in milder cases of hyperparathyroidism, the earlier notion was you can delay surgery, but now the threshold for surgery has rather come down in patients with hyperparathyroidism, given the fact that untreated hyperparathyroidism has been associated in several series with increased incidence of cancer and increased incidence of mortality. So to sum up, if you get a patient with suspected hypercalcemia, we must first confirm whether it is actual hypercalcemia. It's better to get a ionized or a free serum calcium level done. After you have confirmed that yes, it is hypercalcemia, look for clinical features, look for the age of onset, the mode of onset, to get clues as to what the etiology of underlying hypercalcemia might be. Get an iPTH done, which is the very basic investigation after you have said that yes, this patient has hypercalcemia. With elevated iPTH level, if there's an outright elevation, you are dealing with hyperparathyroidism. If it is high normal or slightly above normal, it could also be familial hypocalciuric hypercalcemia, or in some cases, the patient might be on lithium. So you need to differentiate between these causes. Urinary calcium is helpful because if you have low urine calcium, you are dealing with familial hypocalciuric hypercalcemia, and if you have high urine calcium with some elevation in PTH, you are dealing with primary hyperparathyroidism. With low PTH level, the commonest cause of a low PTH level with associated hypercalcemia remains elevated PTH-RP levels, but these are mostly seen in malignancies, which are usually in an advanced stage, usually with metastasis. So the underlying disease in these cases is quite obvious. If you have a low PTH with hypercalcemia and a normal PTH-RP level, you can think of other causes like increased 125 hydroxy vitamin D levels within the body, which can be because of calcitriol intoxication or because of granulomatous diseases which synthesize one alpha hydroxylase to an increased amount. On the other hand, if you have low 125 vitamin D level and normal PTH RP with low PTH and hypercalcemia, you have to consider a variety of other causes, including immobilization, extensive skeletal metastasis, and a number of endocrine disorders, amongst others. So I think that is the basic message. You need to assess your patient based on the PTH level and the subsequent steps. If you have high PTH, you look for primary hyperparathyroidism, localize the disease, treat it definitely. If you are dealing with familial hypocalciuric hypercalcemia, mostly you do not need active treatment. On the other hand, if you are dealing with the advanced malignancies, again, it's mostly symptomatic treatment for management of these patients. Regarding management of hypercalcemia per se, you need to stick to the basics: aggressive fluid replacement. If you have moderate hypercalcemia with symptoms, acute onset symptoms, altered sensorium, or severe hypercalcemia, you need to give the patient calcitonin, need to give the patient bisphosphonates, denosumab in certain instances, while reserving the use of loop diuretics only for patients with concomitant renal disease or concomitant cardiac disease. So with that, I come to the end of this presentation. Thank you for your patient hearing.